Good afternoon, everybody, and welcome to our panel discussion, which is part of our NHS 75th birthday celebrations. My name is Catherine Holford, and I'm the Chief Nurse here at BHRUT, and I'm delighted that we've got such a great panel today to come and talk about what the NHS will look like when it's 100. Matthew's going to start us off with a speech about a reflection over the last 75 years, and then we'll hand over to Jacqui, who will introduce the panel to you. So could you give a warm welcome, please, to our panel.
Hello, everybody. How you doing? Right, I'm Matthew Traynor. I'm Chief Executive of BHRUT. And it'll be my second anniversary in post next month, actually. It's been a fantastic 2 years to be here. But it's a much more important anniversary we're here to discuss today, which is the 75th anniversary of the NHS. I hope you've all had some time to talk to our staff today, to reflect on the way their services have developed, and to think about the way they're going to change for the future. And I think it's fair to say that without the kind of calibre of people that we've got here today, we wouldn't have an NHS we can be as proud of as the one we've got. So can we just have a round of applause for all of our clinical staff? Right, so I want to start, this is a speech about 75 years of history, so we'll be dipping in and out of times past. And I want to start by thinking about the summer of 2012. And that was the summer of the London Olympics. And what we saw in that opening ceremony there was patients and staff from the NHS walking out into the middle of the Olympic Stadium around a huge illuminated NHS sign. I think there was some dancing with beds, if I remember rightly. And that was a sign of how deeply embedded the NHS is in the British psyche. Now, it's interesting, if you talk to people from elsewhere in the world, they were bemused as to why we would be celebrating the health service in that way. Because there is something particularly unique about the role the NHS plays in all of our lives. It's deeply embedded in the stories of our families. And for me in 2012, my wife was sat next to me watching that opening ceremony, 9 months pregnant. And about a week later, actually, we had our first child at the Royal London Hospital. And watching that ceremony, I was not thinking about how are we going to pay for this, how are we going to get through the birth, what's going to be the impact. I knew the NHS would be there for us. And I know from talking to some of the staff that there's been a woman in here today who still has the receipt from when she was born prior to 1948 and had to pay for her birth. And isn't that fascinating that most of us have grown up with an entirely free health service that's always there for us at those critical points in our life? And I think that reason is one of the things, that's why it's so deeply embedded in what we do. And people from elsewhere in the world just don't get that sense of attachment to it. And that's why it's so important as we celebrate its 75th anniversary, that we think about that role it plays in our lives. It was set up in 1948 for the treatment of illness and injury. And not without opposition. There was real concerns about it from some quarters, but actually it was set up, and it's worth reflecting on, I think, what Nye Bevan said at the time. That people, for illness is not an indulgence for which people should pay, and it's not an offence for which people should be penalised. That it's a misfortune, and that the cost of that misfortune should be shared by the community. And so that's the principle behind this National Health Service that we have. That we come together and that we share together in looking after people who've had that misfortune of illness. That we offer compassion without judgment in the way that we care for people. And that's what we get from so many of our staff day in, day out. And that's why actually at this point it's really important to reflect on those founding principles. And since then we've had huge successes. We've had massive vaccine rollout programs, so things like measles, smallpox, the treatment of polio, all these things that used to be responsible for thousands and thousands of deaths that have pretty much disappeared now. I remember having my TB jab at school, the lump of sugar, the big scab on the arm, and before I went into our TB lab the other week, they said, have you had that? If you had that, make sure you've had it before you come in here. But it's great that we've had these programs that have fundamentally changed the shape of illness. And we've moved from a society actually where those kinds of transmissible diseases have been responsible for many deaths to a situation where people live a lot longer. When the service was founded, I think life expectancy was around 68. So some of the first babies who were born in the NHS, the service has already outlasted them. Life expectancy now is a lot longer, but with that becomes a different kind of diseases more associated with survival. So cancer, neurological illnesses and so on, and the kind of treatment we provide for illness and injury has fundamentally changed as a result of those huge successes. We also have at Queen's more than 7,000 babies a year born just in this hospital alone. So 20 a day. So if you think of the number of people in this room, a couple of hundred of us, that's a couple of weeks at Queen's. There's this many people born. That's quite an incredible thing to think about just over the road there. And actually those successes of the NHS are something we should be tremendously proud of. And of course there's another 75th anniversary at the minute, and that's the 75th anniversary of Windrush. We're only 17 miles from Tilbury Docks, and although the NHS is uniquely British in its conception, it's genuinely international in its delivery and operation. There's people from more than 200 countries around the world working in the NHS. 1 in 10 of our staff here at BHRUT is from the Philippines, and there's many of them with us here today. But we are truly an international workforce, and that's why I think it's important at this 75th anniversary that we reflect on how we need to make sure that people who've chosen to come here from across the world feel genuinely welcome in the provision of healthcare. Our hospitals are built on the work and effort of people who live here and who've come here from across the world, and that fantastic diversity is a huge source of strength for the service. And finally, it's a birthday, and that's always a chance to reflect, isn't it? And we've had quite a few years in the service, haven't we, recently? We've had the pandemic and everything that's done to us. And I think there's a sense now that we're starting to recover from that and think about the next set of challenges that lie ahead. But it might sound strange coming from someone who's the chief executive of an acute hospital, but we really need to start moving some money out of the acute hospital system and into the community. The majority of people's health outcomes are driven by factors outside the hospital. We're here to care for people when they're unwell. But I think it's something like they say 80% of health outcomes are driven by how people live, the decisions they make about their diet, about their exercise, the care for long-term conditions. And we really need to look at how we work with local authorities and recognise the huge role they play in people's health. We really need to think about schools and about the generations of children coming through. There's some colleagues here, we've been at recent workshops around here about obesity. In Havering, 69% of adults are overweight. And as you see that coming through and think about the health burden that's going to place on the health service, we need to think more openly about public health and about the kind of interventions we can do where people only need to come to hospital when it's essential. The support we need for primary care, community care and mental health, and how we look at the role social care can play in helping people live to a good old age. So the other thing we also need to do is to really invest in our staff as well. This is a month where we'll be coping within our 2 hospitals with 7 days of strike action. And these are the staff who, if we want the workforce plan to succeed, and it's a really good plan, really good forward-thinking workforce plan that tells us what the health service needs to do over the next 10 years to succeed, we need the staff that work for us now to feel valued, to feel engaged, because they're the people that are training all these tens of thousands of extra staff that are coming through. And so it's great to do things like this, where we can look at the people who work in our hospitals and say thank you to them for the effort that they put in, for their engagement and for the care that they deliver. So the NHS is 75, but it's not a 75-year-old person. It's not in a stage where we're thinking, well, let's look after it now and let's see how the next 10 years goes. It's something that if we value it, and we value it in its richness and its uniqueness, we need to think about how we make sure it's fit for the future. And that's going to be the subject now of our panel discussion. But, 75 years of the NHS, 75 years of fantastic people like you, giving a huge amount of your lives to the care of others. Happy birthday, NHS, and thank you, everyone. Cheers.
Well, Matthew, thank you very much indeed for that introduction to our session today and that look back over the 75 years of the NHS that we're celebrating. Can I start by thanking those of you who've come today to join in our celebrations, to see the fantastic stalls that our staff have put on, and to listen to the brilliant panel that I'm going to introduce in a moment, and particularly to our staff, to my board colleagues, to our patients, and to representatives, senior representatives from our community, from the local authorities that we work with and that support us. Thank you very much, not just for today, but for the ongoing partnership that we have with you. So, turning to our panel. And I'm really pleased that people have been willing to give up the time to do this today. So, firstly, starting on my immediate right, we have Deborah Sturdy, CBE. Deborah was appointed as the first Chief Nurse for Adult Social Care in 2021 in the Department of Health and Social Care, and has got a background in nursing, and particularly with that crucial focus on care. And next, after that, we have Max Geraghty. Max is the Operations Manager for the Care Quality Commission. I won't ask anybody their views of the CQC at this particular moment, but I have to say, Max is one of the good ones. Let's just leave it at that. Next to Max, we have Jacqui Kullar, who's the Clinical Director of the Havering Place Based Partnership, having qualified from Barts and the London, having been involved in research and then becoming a GP, and that a crucial part of that place-based work that is so important for us. Next to Mickey, we have Helen Balsdon. She is the Interim Chief Nursing Information Officer at NHS England, passionate about using technology to support the delivery of high-quality evidence-based care, and was previously the Chief Nursing Information Officer at Cambridge University Hospitals Trust. Next to Helen, we have Alastair McLellan, who's the editor of the Health Service Journal, which all of us know is your source of news and intelligence, the emails you look forward to, mostly, from the HSJ telling you what's going on in the health world. And Alastair, since he became the editor in 2002, has really transformed the HSJ to play that role. And at the end, next to Alastair, we have Mohamed Omer, who MBE. Mohamed's really actively involved in the local community in East London. He's the board member for external affairs at the Gardens of Peace Muslim Cemetery, which is the largest dedicated Muslim cemetery in the UK, and plays a range of other really important roles, including as the director of the Muslim Bereavement Support Service. Thank you to my brilliant panel. And I'm going to start off with a question that came from Eamon Kerr, who says, will the NHS be the main provider of healthcare at 100 years? And I'm sure people will have something to say, not only about that, but what form it might take as well. But because there are 6 of you, I am going to be really disciplined in looking to you for quality rather than quantity, which you are clearly able to do. So let's start with Deborah.
I absolutely think it will be here in 25 years' time. I mean, to get to 75 years is quite incredible. And just reflecting on some of the things Matthew was saying, you know, it is absolutely core to our society in the UK. It's an absolutely essential public service, and I don't think we are going to take kindly to that going. And of course, there is a mixed, and there has been for many years, a mixed economy around healthcare. But I think the essential role of the NHS will very much be here in 25 years' time.
Max.
So, other than the wider existential question in terms of whether we'll all still be here in 25 years, yeah, I think the NHS will be. I mean, I know there's a lot of argument around, decentralising it, and but I think it is a model that will still be here in 25 years. It might look very different in the way that care is going to be delivered, and I know that we've seen that in the last 5-10 years in terms of how care is changing. But in terms of a model of being the main provider, yes, I think it will be.
Thank you, Max. Mickey.
Yeah, I'd have to agree as well. I do think the NHS will still be around in 25 years' time. And as Max said, I'm likely to be a heavy user potentially of the NHS in 25 years' time, so I sincerely hope so. I don't think the NHS in itself, however, could potentially just continue to stand alone. It does need to actually have that wider support. People don't present with just isolated healthcare problems anymore. Life is ever more complex. People are becoming more frail, and the challenges are that much greater. So I'd like to think that it will still be the main provider, but it will need a lot of support from all the partner organisations that it interacts with day to day, week to week, and year to year.
Helen.
I'm not going to disagree with anything anybody said. I think there'll be a plethora of providers of health and social care as we move forward, as it is now. But I do think the NHS is at the bedrock of what we do. I do think it will evolve and change as the needs of our society is changing.
Alastair, will you still be writing about it in 25 years' time?
Well, HSJ, I'm much louder than everyone else. That's good, isn't it? That's as it should be. Well, HSJ, of course, is much older than the NHS, founded first issue in 1892, so we've seen the NHS throughout its years. So, will there still be an NHS? Well, if you want to forecast and do it properly, you need to look at long-term trends. There's a very good book called Super Forecasting, which tells the story of how to think about the future. It sort of says you can actually forecast about 18 months ahead, and you can forecast about 25 years ahead. It's completely pointless to try and do anything in the middle. So, but luckily we are talking about 25 years. And the secret to successful long-term forecasting is to look at the trends that are really deep, under-seated trends within science, public affairs, whatever. I think there is no evidence anywhere you look that the British public, the British government would not want to continue with a tax-funded NHS. The chatter you hear is literally fluff. If you look at all the evidence bases, so I think we can broadly say that there will be a tax-funded NHS. When it comes to provision, the question was about provision. I think, as far for the 21 years I've been editor of HSJ, people have all been telling me how the NHS is being privatised. Well, it ain't happened yet. If it is being privatised, they're taking a very, very long time about it. And I don't, so again, another long-term trend, we pay attention to that. So I think mainly the NHS will be the major provider. However, the NHS is already consuming an enormous amount of public money, and I suspect in 25 years it will probably be consuming over 50% of all discretionary public spending, so more than all other areas of discretionary public spending. That excludes welfare, which is not discretionary, so the money the government can decide on. And that probably won't be enough because of the growing population, the age of the population, the expectations of the population. So what I suspect, again, looking at those long-term trends, is that there will be a lot more people using and paying for healthcare services on top of what the NHS delivers.
Thank you, Mohamed.
Well, I have to agree with the rest of the panel that not only will it be in 25 years' time, but it should be in 25 years' time. NHS should still survive. All of us, it's very easy to criticize a system of NHS, and when you start to compare with other countries at point of care, what they are receiving, you will find that NHS is way, way above everybody else's expectations. So I would certainly very much hope that it will be there in existence. It will also be in a different shape. You will have other providers, but the core will always be the NHS, and it has to be the NHS so that people can have confidence that whenever there is any treatment required, they will be able to receive that. That would be mine. The only other thing I'll agree with Narinderjit, that in 25 years' time, I will have to use the NHS because my age will be there if I'm still alive. And just to give you a perspective, in 25 years' time, I'll be 91. So I don't know whether I'll still be alive or not. But I certainly would like to see that this particular model is there. Obviously, a lot of improvement is required. And as mentioned by Alastair, we will need to re-look at how the NHS is funded, what are its priorities, so that they concentrate on the needs, the real major needs which needs to be done, and the balance of it should be on preventative care. That should be the main purpose of it. That's my question.
Great. So there's a consensus about the existence of the NHS, but I just want to throw another question in here, because we've all of us will be 25 years older and hopefully still here, which means we won't only be using a lot of healthcare, we'll also be using probably quite a bit of social care. So everybody doesn't necessarily have to answer, but you may have a view. And Deborah, I am going to ask you to answer. Should we also have a national care service in 25 years' time?
Well, I think that would be a fantastic thing to happen. I think that equity, what I say all the time, one of my mantras is that we're all looking after the same people. So having a service that is, a national accessible service for everybody, I think would be a really good thing. How that will work in terms of how things are funded currently through local taxation, local authorities, people paying for that care. I think that's a really complicated bit of it that needs working out, but it would certainly be my aspiration as I will be 85 when the NHS is 100, and we'll absolutely be using those services, I have no doubt. I think that is the aspiration that we should be aiming for.
Thank you, and then Mohamed.
I would really like to also say there should be some social care system available. One of the reasons is that I think for a long time in certain communities, it has been an expectation from the families to look after the elderly and look after the people who get at an elderly age. But we're in a society today over here where that framework is not there, and therefore it is essential that we should have a national care system available. Society has changed. People have got different priorities, and therefore I feel that the care for the elderly is absolutely a must. After all, they have worked all their life to contribute to a system. So should there not be a recipient as well of that same care which they have contributed to? And they have already been in the system, so therefore the continuous, as been mentioned by the Honour of our Chief Nurse, needs to continue as well. So therefore I think it's paramount, and I think people need to have that confidence. At the moment, the biggest problem and the challenge faced by every one of us is that when we grow older, how are we going to be cared for? At the moment there's so many restrictions. So I have to sell my house to get my care service done. That level of non-confidence from the community is not there. So I think if we have a system where we have a national care system in place, a lot of the people will have some sort of comfort factor to say, I don't need to worry about it should I get ill. So that would be my comment on it.
I think anyone who works in healthcare can appreciate the fact that without social care, healthcare falls over pretty much overnight. I think that's well appreciated. As stated before, I don't think there's anyone who actually comes in with an isolated healthcare problem that doesn't have a significant social care issue to it as well. I mean, if you look at the workforce itself, that seems to be a problem that no amount of healthcare spending solves. We constantly have vacancies, no matter what budget is allied to any particular project, we simply can't staff those. We have 5 million plus people who work in the social care industry. We have a large number of informal and unpaid carers as well. So, I can't see any reason why we shouldn't actually have a social care service as well, but something that actually complements the NHS. I mean, the biggest disappointment I had, I know Matthew spoke about the workforce plan as being a very good one, is the fact that it didn't actually allude to anything with regards to social care. I think there was one line in there to say that there has to be a social care work plan as well, but I can't see why the two shouldn't be complementary, because ultimately, when we look at our hospital system, to get the most efficiency out of the hospital system, you need to have a fully functioning social care system to actually move patients into, but also to have a fully functional social care system that looks after people before they reach hospital as well. We're an ageing population, we're an increasingly frail population, the needs are more complex, and I don't think you can actually look at one without looking at the other.
That is a lovely, neat segue into our next question, which is about the NHS workforce plan, and it's Ian, your question. Would you like to say your question?
So the NHS workforce plan has just been launched, and it contains some aspirations within it. How achievable do the panel feel the plan to be, and what do you feel may be the effect of AI and digital technology on our staffing requirements in both hospitals and community settings in the future?
Great, thanks Ian. That feels to me like one that we ought to start you on, Helen.
Happy to. I think the workforce plan didn't go far enough with what we need from that digital workforce. I think there's opportunities there, but I am equally aware there's another workforce plan being worked on in the background that's really looking at the digital professionals that we need, whether they are clinical or technical, because to make an organisation's electronic systems work, we need a whole team of people. We compete with industry on agenda for change rates compared to what industry can pay. So there's a lot of work that needs to happen in those spaces. But we also need to equip ourselves with a different set of skills that are going to use keyboards all the time in our work, look at technology. I think some of the work I've done in my nursing space is very much looked at how we share information across the system. And I think it's fair to say we don't always trust each other. And what we share with each other, we start the whole process all over again. And there's some great opportunities to break those barriers down using technology, share information so that regardless of where that person is receiving care, the information that we hold about them moves with them so that we can have all the information at our fingertips to give smarter, faster care that's safer and gives them a better experience of care.
Thank you, Helen. Alastair, let's come to you on the workforce plan and
So the question was, is the workforce plan deliverable? Short answer, no. Slightly longer answer, why? Because if you read the workforce plan in detail, or indeed HHA's coverage of it, you will see that it is predicated on an annual 2% increase in productivity above what's going on at the moment. There's no sign that the NHS is in any position to produce a 2% increase in productivity year on year. Productivity is going down in the NHS, not up, which we may choose to explore. It's also predicated on continued investment in the infrastructure. Well, we've seen how well that's gone with the 14 new hospitals, and an increased investment in technology. And of course, there will be some more money spent on technology, but not enough. So the workforce plan is not deliverable as is currently structured. Actually, I don't really care, because quite honestly, the workforce plan is largely a bun fight between the professions to see who can get the biggest number in a plan. The modelling it's based on is pretty ropey. It's just, it's a big number that looks impressive. And it doesn't really take into account the impact of technology or a whole range of other things. So it's a good thing, because it sort of keeps, it's going to mean some new medical schools are going to open, and there's going to be new training places. So that's a good thing. But as a plan, it's nonsense. In terms of, and would always be nonsense. That way of planning your workforce is a nonsensical way that belongs in the last century. In terms of AI, to be succinct, in 25 years, the majority of healthcare will be delivered digitally.
Max.
Well, yeah, I think we need to think big around the whole innovation piece around science and technology. I think AI has been a big topic in the last year for us all, and there's also been all sort of Terminator-like concerns around it. But in reality, we're on the cusp of something which can transform the way that we deliver healthcare and lift the burden off people who are out there delivering that care. We've already seen, like I'm a nurse by background, so I haven't worked in clinically that much in the last few years, but I understand in radiography how AI is speeding up and making so much more efficient and effective the process there, taking the burden off of the staff by speeding up the process of being able to deliver cancer treatment. And of course, behind that, you've also got technological advances in science. In 25 years, will we be dealing with the same, I know I may be going off topic here, but dealing with the same chronic illnesses that we have today? Will we have been able to undermine them and actually be in a much better place in the same way that we were with HIV and AIDS 25 years ago, 30 years ago? So I think that investment in that level of innovation, I think it's essential in lifting the burden off the workforce, actually, so that the workforce is able to do what they can do. And of course, yes, and everything else that's been talking around there in terms of data and performance, etc. I think it's absolutely essential. So is the workforce plan, what I've seen of it, I'm not going to profess to have read it and to be as much of in the same detail, but I certainly would like to see more in it around that longer term vision around innovation.
Would Deborah or Mickey or Mohamed like to contribute on workforce before we move on to the next one? It's not compulsory, seeing as Mickey does. Go on, fire away.
Yeah, I mean, look, I think we've got to have a plan. I mean, that's the first thing you've got to do. You've got to have a plan. And to be perfectly honest with you, I'm quite up for, supporting unrealistic plans. So why shouldn't we aim high? We talk about smart objectives. Why shouldn't we have sort of almost like SMART objectives? Specific, measurable, unrealistic. We've got to aim high, all right? We've got to aim high here. I do think that there are things that can be delivered in there. I don't think it's the all-encompassing plan that will solve all of the problems that we have. We've spoken about how technology can help. I mean, certainly probably about 15-20% of my time is spent doing stuff that could be done by AI. In terms of how much time is spent writing in notes, for example, typing up notes, filling out referral forms. There's a lot of correspondence that comes through between services that AI could very easily deal with. There's a lot of front-end navigation for getting people into the right place that AI could support with. Helen mentioned about data. I mean, the nirvana for me was the COVID Act 2020 that allowed us to freely share data across organisations and actually work really well, because we have a different view of the system from almost like different faces of a mountain, and it's getting that 360 view to actually fully understand what the system and the workforce looks like. So I'm hopeful that technology can help. I do agree with what Alastair said. I do think a lot of healthcare will be digitally delivered. I think a lot of people will actually potentially have personal health assistants that are digitally enabled. However, I don't think you can actually take that interaction between humans out of healthcare at all. When you look at mental health services, for example, we can... you look at mental health services, for example, very often you have telephone advice that can be given. We have Mental Health Direct that runs 24/7. But why do patients still call 999 and turn up at the UTC front doors? Because they want that human interaction. And I don't think that the message that's given to them face-to-face is any different to what they get over the phone.
In 25 years, the AI will be better at offering mental health counselling than your average human counsellor, I would bet.
But what do you think are the things that only people will be able to deliver in the NHS in 25 years' time?
I think it's that point about that human contact bit, that stuff when you are frightened, which is often, when you're ill, you're frightened, you want that actual, that emotional intelligence, which I don't think the AI stuff is going to solve. And I was just thinking as people were talking about an article that I wrote probably about 15 years ago, talking about technology, and the final paragraph was, and it'll never replace humans, because we need that. Where people, I think one of the things from the pandemic, all the kind of, when you've been working through that computer screen, I mean, I've met people, Helen and I have never actually physically met before yet. We're in meetings and have been for the last 3 years. Jane Clegg was, she's still here, but here earlier. I've never actually physically met her in 3 years. And so I think that human contact, that emotional contact when you're frail and frightened is really important.
Think back over the last 25 years. Of all the times that you've heard that technology would not replace humans in X.
Alastair.
You can think of lots and lots of it, can't you?
Alastair, I think the argument has been that there is a place. Now we're hearing where we think it might not be work. And that is about, this is the answer to your question.
Yes.
Go on.
Yeah. So it is. I think it's about when you're frightened and you're vulnerable, you need a person. And I think as we see an aging population, we know this aging population is going to get bigger and bigger. I think even more so. And although people will adapt to that technology, you still need that human interaction.
Go on, Mohamed.
Yeah. Sorry, I mean, I would agree that the plans, which has been, is very ambitious. I won't say that it's not achievable. It's an ambitious plan, but obviously we have to be ambitious to do so. Definitely more needs to be emphasized on the digital side of it as well as the AI. But I would disagree with Alastair, where he feels that the human element may not be that important. It is extremely important. During COVID, Alastair, you may not know, but during COVID, we've had to handle so many families whose main complaint was the fact that they had no human contact. They are still, even today, in this particular mode, trying to come to terms with actually having no contact at that particular point. So it is important. And for some people, for them to see somebody face to face has more of an effect than just doing some from a digital perspective. That is why even now when we are saying some of the GPs who are offering video calls or offering on the phone, they are still insistent that some of the patients wants to see their GP face to face to get that confidence. So I don't think we can discount that entirely. Yes, it can work hand in hand, whereby we have more digitalization, more AI information used effectively and efficiently to get a better feel for the person's condition, definitely. But I cannot see that we can lose the human touch. I think that really is not that was never the objective of the person when they set up NHS, and I didn't say that. And I have also been, I'm not clinically involved in here, but I have been in the healthcare system, and I have worked all over the world with healthcare systems, in Africa, in India, in Middle East. I do know that the main element of it is the human element as well. That is why people will sometimes want to go abroad to get the treatment done, because they'll be able to see somebody face to face in order to get that treatment quickly.
Right. I'm going to move us on actually now to another issue about which there may be some debate. And this is an issue that has come from our patient partners. And their first point is more emphasis on prevention and education to avoid ill health. So to turn that into a question, how much are we and factors outside the NHS responsible for our health, rather than depending solely on what happens within the NHS? I'm going to start with Max.
Are you suggesting by that question how much are we responsible for, like, giving up smoking and not drinking too much? Is that what you're putting the onus on? Well, yeah, I mean, because I don't want to go back to the last question, and a bit controversial, but I am inclined to, with part of what was said, that Alastair was saying there, I partly agree. In 25 years from now, I think the landscape is going to be very, very different. How we fit into that, how it looks like, the technology, what AI is able to do, but yet we still make choices, and our health is not going to, the things that impact our health are still going to remain the same. And I think there's a huge socio-economic issue here, which is bigger than just healthcare, isn't it? In terms of pollution, for example, and how we invest into closing that gap between the deprivation and the inequalities and the variation that exists throughout the whole of society. Why people still smoke? Forgive me for you as smokers out there. Why we still have smoking even allowed in 2023? That's always been my personal bugbear. But of course, we have choice around all of this, and I think health promotion, of course, is essential. It has to be. And I think investment into that to try to cut off those chronic illnesses, those chronic diseases, which are a huge draw on the resources of the NHS. There is something in that which we have to take responsibility for if we're going to work with everything else, whether that's the advent of AI and technology, whether that's the advent of other scientific and innovative breakthroughs in technology as well, moving forward, then surely we've got to take responsibility for that as well. But that's, it's a hot topic, isn't it? It always has been.
Mickey, in the place-based partnership.
Yeah. I mean, I guess the one thing that we've always kind of struggled to really get to grips with are those wider determinants of health. And as Matthew mentioned earlier, these account for up to 80% of the quality of your life and also the quantity of your life expectancy itself. So, I mean, how much can we as healthcare organisations actually influence those wider determinants? These are things related to housing, employment, education and income. It's a huge amount, and it's it's a very difficult thing to actually grapple with. If you look at when the NHS was actually conceived, they appreciated that there were these wider determinants of health and the impact that they had, and yet 75 years on, we're still trying to grapple in terms of how we can actually influence this. We speak about lifestyle choices, but many of these lifestyle choices are based around socio-economical deprivation, and how can we actually influence those wider determinants? These are bigger sort of social problems that we have to face as a country, and not just as an NHS. It's such a difficult thing to say, but we also have to appreciate that even with the best healthcare, this is only 20% of your health outcomes that we can actually get from the very best healthcare. So how do we actually influence those wider determinants? One thing we can start to do is start thinking about integration as not just a vertical system between organisations, between primary care, community and hospitals, but also how we integrate horizontally with regards to schools, how we actually integrate with social care, local authorities, our leisure centres, for example. You know, we're very fixed with this idea that healthcare professionals have to work in hospitals or clinics, but really, in all honesty, we have to diversify our workforce to actually cover these wider determinants and actually draw them into this wider workforce itself. So it's a difficult one. It's one that we have to work on, and I think this is the whole principle behind an integrated care system. And it has to be fully integrated and not just viewed from that prism of healthcare organisations themselves.
Deborah.
No, I just totally agree with what Nikki's just said. It is about that integration piece and knowing your communities and actually being responsive to the communities in which people who use our services live. And actually, I think it's about that public patient involvement in stuff as well. It's how do we, really think about diversity and inclusion. And I agree, if integrated care is really going to work, then it is actually sitting around the tables with absolutely everybody. Social care being, I would say it, wouldn't I? But social care being at the absolute forefront of that. And public health as well. Our public health colleagues are absolutely critical in this. So I think we've got to truly walk the talk, not just talk the talk about integration, if we're really going to make a difference to the health and well-being of people in our communities.
Alastair, integrated structures or personal responsibility or education? What is it?
So one of the pleasures of my job is that, unlike most of my fellow panellists, I don't have to tell you what you want, what you'd like to hear. So I think if you want a healthier society, you need a more equal society.
Yeah.
Now that is the first thing to say, and that's a bigger political question, but all the evidence is equal societies are healthy societies, and this country is becoming a less equal society. So that's an issue there. When we come to public health, as we sort of understand it, the health education promotion side of things, for policymakers in Britain, it's a really difficult one. Some really interesting polling that Ipsos Mori did a while ago, where they basically looked at the attitudes of British, French and German people to public health messages. In Germany, they expect the government to tell them what to do. So, it's very straightforward. They expect them to tell them how to live healthy lives, and they're very receptive to messages as a result. The French, absolutely, they don't want to hear it. They don't want to hear the government telling them how to live their lives at all. Luckily, the French are quite healthy anyway, so that works out all right. But Britain, it's right down the middle. 50% of us want it. Lots of those, I imagine, working in health and care, and 50% don't want it. And it's a really difficult problem for British policymakers, because you cannot do health prevention, promotion, etc., without the agreement of the population. It just doesn't work. They find ways around it. If you don't, the best example is prohibition in the before the Second World War in America. That was a massive public health and to a certain extent public morals intervention, which was a massive failure because it didn't have the agreement of the population. And that's the real challenge in Britain, is that actually it's really quite hard to get a sort of critical mass of people around any kind of intervention. Not impossible, as we saw with smoking indoors.
Mohamed.
Alastair, I agree with you that we need an equal society in order for us to ensure that we've got equal health treatment for everybody concerned. I would agree with the rest of the panel that we need an integrated approach. And a lot more should be concentrated on preventive measures so that we can be able to tackle all these the major diseases using AI, using digital technology. I would also like to say that, there are so many health inequalities in this particular country that unless you address that, you're not going to be able to tackle the root of the problem. And that was extremely apparent during the COVID time. And specifically because we happen to be in the borough, which is deprived, like Newham and Redbridge, Barking and Dagenham, all these areas, we saw at the other end of it, the number of people who succumbed to COVID was much more significant from those areas than any other areas. Also, there has to be a lot more engagement done with communities and those marginalized so that we can understand better what they would require in terms of support so that the community can be able to identify. And thirdly, we really need to analyze that why are certain illnesses happening in certain communities. This is something which is extremely important so that we can try and tackle those problems using either the community workshops or something of that to pass the messages across. I think that also is important. And I would like to agree with Narinder when he said about during the COVID period, you were able to share information. Now that is extremely important, and the reason given to us today is that we cannot do so because most of them don't have the same software. Surely this is an easy solution to sort out. Why are you worried about software when you were able to do that? Why can you not do that now? So, this really beggars belief to me, right? And we are hoping that with the digitalization of the MCCD, we are hoping that they will be able to get some information which will be able of value so that people can understand in certain communities. And from my very selfish perspective, I would always, we don't have, for example, any way of trying to collate an information from any statistic to say how many Muslims died, right? And unless we have that figure, can we then go back and say, well, if this is a Muslim, then what was the reason for it? We cannot address that because that information is not captured.
That's a really important point, and I'm going to finish with Helen on this round. So Helen, data and information, it's easy. Why aren't we doing it better?
If it was that easy, we would have done it by now. We probably would have done it when we started the national programme for IT many years ago, before my time in many respects. It's difficult and technology is moving all the time, but I think with the integrated care boards, we've got new opportunities to really understand what data means something, what's there, but we need to take a long-term view, not a short-term. The agendas, I think, for the NHS in 25 years' time will be more about prevention, but we need good data to help us also do risk identification of people that don't know they've got a problem before they've got one, so that we can be less about an ill health service and more about a well-being and keeping a healthy populations. But we've also got to start by educating those that are being born now and bringing that through so they get that information at an early stage. Use our digital systems to record things like those social determinants of health. Because at the moment, I suspect every time a person gets an interaction with a healthcare service, whether it's primary care hospitals, we may or may not write it down, but we certainly don't share it. So that person's having to repeat their story. We've still got social burdens about what people feel they can say and what they shouldn't say. But we're only going to blow that open if we use the data that we've got and really support people to contribute to their own records. It not just be about the professionals recording things.
Okay, thank you. Let's move on to the next question, which is from Paul. I think it's Paul Mulligan.
Is there going to be a link between industry and the NHS? I mean, you're talking about data there, which as an industry, we use an awful lot of data. So what I want to understand is, are the NHS going to link with industry to try and reduce the impact and costs on the NHS by using what we deliver to our employees, etc.?
Which industry do you work in?
Construction.
Okay. But let's address this more generally as links between industry, wherever it might support the NHS, and the NHS. How do we do that without charges of privatisation? How we do that in a way that is effective? Let's start with Helen again.
The words that are coming through my head, whether right or wrong, is that new hospitals programme, because much as it might be taking a lot of the resources, there's real opportunities in there to look at how we integrate new technologies into a building's infrastructure, and it not just being about recording of the individual care, because there's a lot more we need to do to use that technology to help us be more productive. You know, how do we move supplies around an organisation? Generally, we move them by somebody knowing where they're going, but actually there's tech that can help us do that smoother, take out humans where we don't need them. There's many places we still need the humans. And I think really help us do that to keep the buildings good temperature. Sometimes hospitals can be very hot or very cold. How do you do that? So I think that relationship we're starting to see really come to the fore with that new hospitals programme. And I think there'll be lots to be learnt for the longer term.
Alastair.
So the NHS has always been a joint venture between the service and its suppliers. Everywhere you look, the NHS has never built its own hospitals or indeed manufactured its own drugs. Though Jeremy Corbyn wanted to do that. He wanted to produce nationalised pharmaceutical factories. And there's always been that tension about how the NHS works most successfully with industry. And I won't bore you with the endless reasons why that relationship doesn't work so hard. I will just simply say that where there is trust, where there is a proper understanding of the risks taken on both sides, then good things tend to happen. And there are lots of reasons why that doesn't happen in a lot of cases. But the idea that somehow the contribution of industry, whether it be the pharmaceutical industry, the technology, care services, construction and other professional services, that the NHS can prosper without an effective partnership with those sectors is for the birds, because it always has, and it's always succeeded best when it's had that most effective partnership. There are ills on both sides, don't let me get it wrong. There are plenty of pirates out there in the private sector who've taken the NHS for a ride. We can see that in the PFI programme. But, it's an essential part of delivering an effective healthcare service.
We're coming towards the end of our time, but I want people to have the opportunity to answer this where they've got something they want to particularly add on the industry link. And so let me go to the final thing that I want everybody to wind up with. I want you to tell us your final contribution. What's the biggest hope that you have for the next 25 years of the NHS? What's the biggest fear that you have for the next 25 years of the NHS? And let's start at the end with Mohamed.
Biggest hope I have for the next 25 years is I would like to see an NHS which is run efficiently, which does not have any waiting lists, which will be able to provide the care which is expected by all its patients. This is what my vision would be and my dream would be. My biggest fear, I do not think we have got enough funding or enough manpower to fulfill that. So that's my biggest fear. But I certainly believe in the NHS system. I think it also needs to be more integrated as well as have more diversity in its entire NHS force, be it employees, be it anything. That is essential for me for an effective NHS to work. So that would be my vision, so that anybody does not have to worry about to say my appointment has been cancelled. And the last thing I would say, I want to once again create a confidence factor when people are no longer scared to go to the hospital that they will not come back alive. That has been the problem during the pandemic, when a lot of people had that problem to say, I don't want to go to the hospital, and they refused to go to the hospital because they were scared of the treatment they would receive. I want that assurance for the community to have, that it is safe to go to the hospital, you will get provided the best care possible, and you will come out being treated.
Alastair.
So, the thing about the NHS is it really touches all parts of life, which is why it's so interesting to write about it. We live in a time of the 3 Ps: populism, polarisation and post-truth. And that affects the debate around healthcare as much as it impacts the debate about anything. My hope is that we are not, that debate is not taken over by those 3 Ps, and we can have a proper debate about the really complicated, challenging, long-term issues that well-being in healthcare pose to any society. My biggest fear is that we won't, and that the 3 Ps will triumph, as they have in many so-called democracies, and we'll end up with a much more unequal society and a healthcare system under much greater strain and with a bigger question mark over its future.
Helen.
I think the NHS's biggest asset is its people and its workforce. And my hope is that they will drive this digital agenda forward to make sure that the technology works for us and makes it easy to do the right thing, and that we harness it to reduce some of the burdens we've got. My fear is, with the pace that we're working at the moment in all areas of care, that nobody's really got the headspace to think creatively about how we do that for the long-term benefit.
Thank you. Mickey?
So I guess my biggest hope is that we turn into a more sort of proactive healthcare system rather than something that's very reactive. So something that generates health rather than just deals with endless sickness and illness that presents at our front doors. That we actually function as one organisation and not as a number of disparate organisations that seem to have this endless bun fight over limited finances and competing for various different contracts, etc. That we function as one single health and social care workforce itself, and actually have a great appreciation for the different roles that we do. That we do actually start to think about prevention. It was raised earlier in the question that someone brought about. The Hewitt Review talks about a 5 times increase in the amount that's spent on prevention, but 5 times of not very much is still not very much. And really we need to have a serious think about what we're doing here. Someone mentioned about Havering being the most obese borough in North East London. It's the second most obese borough across London itself. So we have the dubious pleasure of and distinction of being the largest by geography and also largest by waistline. We do need to do something about obesity itself. It's a very specific area, and I think unless we start tackling this, we're just saving up lots of problems for the future. My biggest fear is that we don't do any of this, that we spend all our time doing what we've done so far, which is putting out endless problems and endless fires if and when they occur, without actually developing that long-term view, because that seems to be something that takes up an inordinate amount of time that everyone seems to be focusing on, is dealing with the problem at hand rather than actually thinking into the future as to what we're actually investing in. I guess my other fear, and this is probably a bit more light-hearted, that given the fact that you're filming, this doesn't turn into a Back to the Future moment of hoverboards and flying cars that comes to bite us on the backside of the future. But I'm hopeful that we'll eventually reach the place that we want to be, which is a healthier, fairer society and a healthier, fairer, younger generation coming through, and not only a better quantity of life, but a better quality of life for everyone.
Max?
Yes, I mean, I was thinking of that around the whole inequality and variation, etc. Being able to close those gaps, and words like collaboration and integration and innovation. I mean, they're the words that, my hope is that we're an NHS that really models that and really does continue to strive to set that example to the rest of the world in terms of how we deliver our healthcare. My fear is, in terms of what Helen said around staffing, the staffing is so essential. The time that I've worked in healthcare, it's been the people and the heart and the soul of the people that make it happen. Everyone goes the extra mile working in healthcare, who I've met, and people get out of bed in the morning to do something different, to do something radical, to change the lives of people. And I think my biggest fear was that heart and soul would disappear because we lose, it doesn't get looked after, basically. And we're on a very scary place at the moment, aren't we, in terms of where politically the NHS exists, and it's almost want to sort of remove the bipartisan sort of element from it and just allow everyone to embrace it and have that collaboration and to make it not lost. So yeah, the people are amazing, aren't they? You don't want to lose the people.
Quite right. Deborah.
Very hard to go last on this one, because I agree with much of that. I think for me, my greatest hope is that we really will shift things away from the centre of gravity, which is always the acute hospital, and I think that we should be renaming them health tech centres, because that's actually what they are. You go and do your technical bit there, and that we really do develop more in terms of community response, because I think that's probably what I want, but I'm sure what lots of people want. So I think we have to sort the money out and shift that to where it really needs to be. And I think that, for me, the hope that we really will get to a place about integration where there is a parity and equity, about recognising the contribution social care makes to health truly as a partner. So I really want to see that happen. And my greatest fear, I think, is around the workforce. I think it's a bit of a hope and a fear in one, really. I hope that we really can recruit the number of people that we need across both health and social care to meet the growing demands of our ageing society. But we have the people with the right, we have a bit of Helen saying about that headspace bit, having the headspace to think and do things differently, and that we get those people to have the requisite skills and knowledge in the right place to give the best care for collectively the people that we all serve.
I feel as if we have only just got started, but sadly we must come to an end. And the reason it was so lively was because of the fantastic panel. So please, can you give the panel a very big thank you?